Today, we're exploring a topic that may be triggering to some listeners. While psychedelic-assisted therapy can be a great option for some people, this discussion may be triggering. If you're struggling with substance use now or in the past, or even if you've had a loved one who has struggled with substances, I want to make sure everyone's prepared before we dive in. If there's even a chance that this topic could trigger you, just skip it, and we'll reconnect in the next episode. Hi, welcome back to Therapy Unboxed. I'm Lana Seiler, and today I am joined by Anthony Gonzalez. Anthony and I have a really special history. He was my supervisor for licensure, and anybody who's gone through that process knows the ups and downs, the challenges, the nerves. So during that time, Anthony and I built a really strong bond, and he can tell you this, I still reach out to him today from time to time, emails and texts. Hey, do you have a second? Can we talk about this? I have a question about a client. Anthony's an incredible clinician. He's primarily a DBT trained clinician, and also has done some amazing work with PET, which is prolonged exposure therapy. And I've had a few supervisors in the past, and they've all been wonderful. But I have to say, Tony has been sort of a kindred spirit with me in the passion and the creativity and determination to help people struggling with specifically trauma. But he has a wide array of skills and abilities. And today we are going to talk about psychedelic-assisted therapy treatment, which I'm so excited to talk about. This is a huge sort of topic right now in behavioral health and mental health. There's a lot of buzz about it, and I'm excited to dive in a little bit deeper because this has been his most recent baby. Thank you so much for being on.
Thank you so much for that beautiful introduction. You humbled me. I will say I'm just incredibly grateful and excited to see all the wonderful things you're doing in your practice and in your clinical world, and seeing the leadership you have as you transition into your role there, and that this Therapy Unboxed with Lana, that this is amazing, and I'm just super grateful to be as a guest. So, as you said, I'm been in the field for a long time. Primarily, I would say the last decade, really focusing on becoming the best trauma therapist I can be, learning the advanced protocols for prolonged exposure with DBT, being level 2 trained in EMDR, internal family systems, and this area of psychedelic-assisted therapy is something that I've really become much more passionate about in the last 2 or 3 years, and was very grateful in the past year. There's a lot of hard work that went through the MAPS training, which is the Multidisciplinary Association for Psychedelic Studies, which is the leading research and advocacy body in the nation and the world, really. I went through their therapist training last year. It's a pretty intense 5-6 months range of study. And so I've finished that training. I have not done my clinical work because there are no research sites here in Florida, but hopefully that will change soon, or I'll find a place around the country where I can do my clinicals and become fully trained and immersed in this work. Thank you for having me.
So exciting. I'm so glad to have you here. And I'm just going to say this now, and I'll probably say it again, but I'd love to do another episode with you to dive even more deeply into this, especially as you continue on with your work, which is super exciting and impressive. So let's back up just a little bit. I'm going to talk a tiny bit about sort of the history of psychedelics emerging in the sort of clinical world, the treatment world. And this isn't probably new to anybody, but we'll go through it. I want to say that kind of roughly from the 1950s to the 1970s was the first wave of interest in psychedelics for the purpose of clinical work with people. And I guess the most famous name is Timothy Leary, who was a Harvard-educated researcher and worked at Harvard University. He's most well known for his interest in LSD, but he also was involved in the psilocybin project from 1960 to 1962. And I know, Tony, kind of your area of focus is psilocybin and MDMA, so we're going to focus on mostly those two today. And also probably not news to anyone is that, that movement didn't continue. It sort of died out. There was some controversy, and we're going to talk about this. I'm going to let Anthony expand on it a little bit more about sort of this dual view, right? Some people are kind of seeing this as more of like a metaphysical, spiritual journey, and other people are seeing it from more of a scientific lens. And so eventually there was some, controversy and some questioning of the professionalism and Timothy Leary's research. So eventually he was let go, and then it stopped after that. I think there was sort of a stamp put on psychedelics that they're not helpful, that they're substances that can be abused, and we moved on as a discipline to other things. And so there's been a revival, which is interesting. And this new revival has come out of, I think, hearkening back to Timothy Leary, we are taking a strong look at set and setting. So we're looking at the physical environment in which we're exploring using these different substances to help assist in treatment. And we're looking at the psychological expectations. So the set, like how are we using these substances? What are we hoping to gain? What are the parameters? And what's new, and I'll let Anthony jump in here too. What's new is looking more deeply at the relationship between the clinician and the patient as a critical element of facilitating this healing. So this is the sort of new paradigm in exploration of these tools potentially for use in therapy. Tony, do you want to pick up there and talk a little bit about what's happening now?
Well, I just kind of go back a little bit what you're saying. I would say that the movement didn't necessarily die out.
Okay.
It was stopped in some ways very intentionally. That, when moving from the 60s into the 70s, American law kind of moved into this war on drugs. Yeah. And for, a lot of reasons, and I have a whole opinion about consequences of the idea, but they're, in the 70s and the early 80s, when all of these things that had a growing database of research and support their effectiveness were scheduled. They got scheduled as Schedule 1, meaning there's no medical benefit, and research had to stop suddenly and immediately. And so I think, we lost 20, 30 years of understanding from a scientific and medical standpoint the impact of these medications because of the position that the federal government took on these things. Now, there was a lot of underground research that continued, but obviously without the controlled nature of it, it's hard to implement that information to how we would standardize it today. So it didn't die out in that sense, but the changes of the perspective of the government that kind of put it to a halt. And thankfully now that we're starting to see, I know we'll probably get into the legal legislative aspects of this a little bit later, but it's starting to, as you said earlier, gain revival and gain a deeper understanding of the potential of these medications and substances. Many areas, but primarily right now in areas of mental health.
Yeah. Thank you. That's a really good distinction. Yeah, because it also adds some context to what it looks like for us exploring using these tools and medications now too, because there's a lot there. It's not as simple as just the scientific community. It's also a lot of biases, a lot of beliefs, a lot of feelings around this. So that's a very important distinction.
Well, a lot of stigma that for decades now, these things have been seen as recreational drugs.
Yeah.
And in many ways used as recreational drugs. And so I can validate where, you know, our society and our culture's perspective has come from, and we're conditioned on this. And that's a big part of what those of us who want to be clinicians in this field are trying to work toward, changing the viewpoint and changing the perspective and changing the stigma on what it means to use these substances as medications, as controlled medication, as research-based, evidence-based medications. And so we have a stigma to overcome, but I think we're slowly whittling away. Every single study that comes out that shows efficacy in different areas, we're gaining traction.
Let's talk a little bit about MAPS.
Okay.
If you would just share a little bit about that program, some of the leaders in that program, and then we'll jump into some misconceptions.
Yeah, absolutely. So MAPS kind of was developed in response to the scheduling, or the scheduling of MDMA, because MDMA has been around for a century plus. It was developed by, I believe, Merck, the big pharmacological company, and it was used for a lot of things in the early part of the last century. And when it started to be used as more of a recreational substance, obviously the government did what it did, and Rick Doblin, who spearheaded most of this research and the passion behind showing the benefits of this as a psychotropic medication, started MAPS in the early 80s. And so it's been kind of started very small, but has been growing and funding pretty much most of the research around the world as far as the use of MDMA to treat PTSD. And now there you have sites around the world, and even many here in the United States, that are conducting regular research. I believe the MAPS headquarters here in the United States are in San Francisco, if I'm not mistaken. And I know they're in California. I believe they're in San Francisco. But they've actually, kind of moving forward to now, they completed phase 3 studies. Thousands of participants in these studies have shown the benefits of the MAPS PTSD protocols on alleviating post-traumatic stress disorder. And the most recent research, at least the data that was submitted to the FDA about a year and a half ago, maybe close to 2 years ago, showed that 2/3, about 66-67% of people who enter meeting criteria for PTSD and they complete the treatment course no longer meet criteria for PTSD.
Wow.
And obviously in our field, we would never say cure, but through these protocols, they're showing significant alleviation of the most intrusive symptoms of post-traumatic stress disorder, which is amazing. For you and I as trauma therapists, we know that, and this is actually in many ways why I went on a journey to wanting to understand this more, is because it may take a year to 2 years for some people to even get ready to talk about their traumas.
Yeah.
To talk about the things that were done to them, to talk about the things they've experienced or witnessed. And obviously as clinicians, we would always be patient in providing skills and developing the relationship in order to support somebody in being ready. And that always, as much as I have a passion for the use of prolonged exposure therapy, and grateful to Dr. Melanie Harned, who is my teacher in this area, but it often would take so long. And I see people suffering, and you see this as well. And it's like, how can we find better ways to get people ready and help them feel more capable of confronting the traumatic memories of the things that they went through or were done to them. And I think that's where these substances and these medications are such a leap forward, because they help to circumvent our brain's natural protective uh, defenses.
Yeah.
And so, I mean, and we'll get into that in a minute, but I think that the MAPS is showing through its research that this is successful, a successful majority of people. And we're understanding more. And I just say this qualified, I don't represent MAPS. I follow what they do. I was trained by them, but I am in no way a representative or spokesperson for them. But I think the research those amazing clinicians and are doing is showing that even the people that through this process, that we can help more people faster. So, which ultimately, as a clinician, that's what I want to be able to do and help people with, is how do I kind of alleviate from these life-limiting symptoms.
Yeah, I'm trying to contain my enthusiasm and excitement right now because you know that this is what we do all day, every day, and I have, we see it, and the sad, tragic part of it is we also see people who don't make it. We see people who end up, losing the battle, either through overdose or suicide, and a lot of the time it's because of what you're talking about. Like, they can't get there. It's too scary. It's too much. The symptoms are too intense, and anything that can help people get to the place that they're ready is amazing. And I'm going to get into misconceptions because I don't want to as excited as I am about this, I know there's a lot more that we have to do, and there's a lot of research out there that needs to be done, and nothing is, a cure-all. So one of the things I was thinking when I was sort of mulling around about psychedelic assisted treatment is that it seems to be that there's an all good or all bad camp. It's almost like we get into some splitting, with it. Some people are super excited and this is the magic cure and this is the most amazing thing. And there's also this all bad of nope, the government has said it's bad and wrong, therefore it's bad and wrong. And we shouldn't look at it. We should look at other things. Does that sound, have you seen that at all?
Yes. I mean, I think that's the cultural debate we're going through right now, not only externally, but internally. And I think as a good DBT clinician, the goal is always to find the middle path. What's the kernel of truth in all of it? And so I think, to your point, there's a great deal of research that exists that shows it can benefit a lot of people. Now, I will say that, particularly for Mdma, assisted therapy, there's going to be rule outs. It's methylene dioxide methamphetamine. It is a stimulant. And so anybody with, pre-existing heart conditions, pre-existing blood pressure issues, they're going to, one of the important parts of screening and preparing is a full medical assessment and making sure someone is physically capable of tolerating the treatment course. And so for that person with a heart condition, it might not be good for them. Psilocybin, there's kind of ongoing research and debate of somebody that has a psychiatric or like a schizophrenic type disorder or a bipolar disorder that has the potential to go into a manic type episode, it might not be good for them. Again, a lot of research to be done. I think that conversation around there's so much exuberance right now in the news and a lot of corporate entities that are trying to move into this. That scares me a little, because I'm old enough to remember when opiates came to the market and they were treated as a cure-all for everything. And look where that's led us as a society, to an opioid crisis, where, keep in mind that the hospitals would give opiates to treat PTSD.
Wow. Just
to numb the pain.
Yeah.
I'm old enough to remember when Adderall came to the market, and everybody got that. And what that, the consequences that had for part of the generation. So I think we need to have temperance as we move into this and ensure that we are being very diligent about who these medications will benefit, who they have risks for, and the scope of who they'll benefit and what type of benefit they have, because I never, as a clinician, want to overpromise and set somebody up for hope that could be disappointing and potentially even further traumatizing, if that makes sense.
Yeah.
And so that the conversation around who will this benefit, and for now we know MDMA benefits people that have PTSD if they meet the baseline medical criteria. The early research that I have studied and aware of with psilocybin, we know from early research out of Johns Hopkins that it helps people with treatment-resistant depression, major depressive disorder. There's early research showing the benefits with addiction and psilocybin, particularly alcohol abuse and dependence. And there's a lot of reasons for that. And I think there's even right here in South Florida, the Siegel Trials is doing research with psilocybin and for addiction, for PTSD, for depression, for anxiety. And I'm excited to see what they're finding and hopefully cast a broader net and who and how we know we can help in using these medications. I think it's in all things in research, we need to know first.
Yeah. This leads me to the next sort of question out there that I hear a lot is people with addictions, actually, because these are drugs that have been abused and can be abused. And so I think there's sometimes a question about, is this appropriate for someone who has an addiction? And I'm hearing you say that there's some promising research about psilocybin being helpful for addictions, alcohol addiction in particular. But can you speak to that a little bit? Because I know that's floating around out there.
Yeah. So to my knowledge, the research with MDMA, they tend to rule out people with active addictions as far as the current research on PTSD. So this is an outstanding question we don't know. What we do know is of all the research that has been done, there's been no consequence of becoming addicted or dependent on MDMA post-treatment course. So I guess ultimately what the bottom line is, administering this medication is not creating a dependency, which is one of the fears, right? And the same is true with the psilocybin research that I am aware of. Administering this medication does not create a dependency nor addiction, which is the fear. It's like, okay, because they've been historically used as recreational, is somebody going to develop a desire to want to keep doing this? And as of right now, the answer is no. What we still have a lot to learn about is somebody with an active addiction to opiates, to even cannabis or benzos or any of these other kind of illicit substances, how can they be used to benefit that? What we do know is in the early research in psilocybin is that they can actually help with the detox process from alcohol. And there's some early research that's showing when administered on the protocol, it can actually help kind of rewire the brain and not have the urges to use that substance anymore. Now, we have a lot of replicating, a lot of peer reviewing to do, but I think that there's a lot of hope in that process. And we can talk a little bit on what we think actually happens in the brain to benefit that, but it's fascinating to see the benefits so far.
Yeah, that's amazing. I do want to get into sort of the details, a little bit more of the specifics about both psilocybin and MDMA. But before that, I wanted to check out, I heard you say MDMA we're looking at mostly for PTSD and psilocybin we're looking at mostly for treatment-resistant depression. Has there been anything about anxiety? Is there anything else that's being found about?
So I would say with MAPS, they are only, as of right now, they are only studying effects of MDMA on the treatment of PTSD. That was the data that was submitted to the FDA, which is wonderful, that it's actually been fast-tracked and designated as a breakthrough treatment. Still scheduled 1, but that's a separate issue to resolve. But that it hopefully in the coming year, coming 12 months, the FDA is going to review and hopefully approve the protocols that PAPS has put forth as an approved treatment through the federal government. But that's only for PTSD. So we know trauma is in the scope of anxiety, but I am not familiar right now with the data or any concrete data on the treatment of like generalized anxiety, phobias, panic disorder, anything along those lines. There may be, I'm not sure 100% on that. I know there's research ongoing, and there's a lot of hope that the same mechanisms can be helpful in alleviating the symptoms of anxiety. But there's a lot of research still to be done.
Yeah. Okay. Yeah, that makes sense. And I'm sure, there is, of course, a trickle effect positively, right? If someone is feeling less depressed, they're going to feel better all around. If someone's not experiencing these PTSD symptoms, they're going to feel better all around. So I recognize that piece too. And I want to go back just for a minute to the addiction conversation, because I know when people think of let me see. I want to talk about this conversation around, is it a spiritual experience? Is it a medical issue?
You're trying to get me in trouble, Lana. You're trying to get me in trouble. No, I'm just kidding.
I know you're up for it. I want to talk about that. And I also want to talk, just before we dive into the ins and outs, I want to bring up the fact that there are other psychedelics that people, have been using and use sort of unofficially, obviously, like ayahuasca, peyote, DMT, ibogaine, with this sort of like hope that it's going to, stop their cravings and the addictive process for them. So I just want to say that out loud, because I imagine some people who are listening are wondering about that piece too. And then let's get into, we're dealing with medicine, we're dealing with, spiritual experiences.
Yeah. I mean, all those, all the ibogaine, which is actually the strongest psychedelic we know of, peyote, DMT, ayahuasca. We've all seen documentaries on Netflix about ayahuasca. So, and I think for me personally, if somebody chooses to go on a spiritual journey with using those substances, guided by a shaman or a medicine man or woman, that is okay. I have to, as a clinician and as a behavioral scientist, I have to look at what we can know works, what we can look at and study and see and repeat and replicate, so it is safe. And so I think if those substances are to ever become more of a readily available substances to treat mental health conditions, they need to be researched. They need to be studied. What is the setting? What are the dosing? The rule ins, the rule outs, the preparation process, all these things that I think the entities that are studying psilocybin and MDMA are doing right now in a very responsible way. There needs to be entities that are also studying these other substances, because as of right now, my personal opinion is those tend to fall into the other camp of their substances to access the metaphysical.
So there is a buzz about this now, right? You and I have both mentioned that there's a lot of excitement, there's a lot of talk, there's a lot going on around the use of psychedelics in a therapeutic setting. And I'm wondering about the pop culture element of it, right? The Netflix, documentaries and the presence online of people who are, using MDMA, psilocybin, and these other drugs in order to sort of further themselves spiritually and or heal themselves. Is this pop culture element helping? Is it hurting? How is this fitting in?
Can I take both? Is that an option? I mean, I think it's helping in the sense of bringing to the forefront the conversation that there's still a lot of gaps in the current medical model of how we approach mental health and how we help people. There's still a lot of gaps. And if these medications can help fill that gap, then it's raising the question. And there's people that are doing the experimentation or doing the ancient traditions of working with a shaman and going on, you know, journeys, then great, it's bringing out the conversation. And I think it's forcing us as a medical field to confront it in the responsible way that we should, right? It's hurting from my perspective because I think it's casting way too far of a net.
Yeah.
It's saying that, well, anyone can do these things and they'll be healed. Anyone can do these, you know, go to Jamaica or Peru or Mexico or Africa and go on these journeys and they'll be healed. And so I think that for us, for me personally, that it's hurting because it makes the research a little bit harder.
Yeah.
Because it keeps the stigma present, if that makes sense.
Mm-hmm.
That these are just things that you go do and they're dangerous and they're risky and maybe they help, but they're probably not because they're done in a jungle or in a hot house or something along those lines. And that's not, I don't mean to sound that is a less than, because I absolutely want to acknowledge and honor the roots. And I said this in a talk a couple months ago, that it's not lost on me as the son of a grandson of Mexican immigrants, that the first person to bring psilocybin mushrooms to the Americas and bring it out front was a Mexican medicine woman, you know. And I don't want to lose sight of that, but I also I think we have a deep responsibility to ensure this is as safe as possible for anybody who wants to access these medications to improve their mental health or to help wrestle with the struggles that you're having with them. And so I guess that's, not to be repetitive, but I think it is both. I think it's helping to promote the conversation, but it's hurting in a way because the conversation isn't nuanced enough yet.
So I know there's a lot to talk about with this topic, and we have barely scratched the surface. And I'm serious. I would love to do a part 2 with you, if possible.
I'm open.
Yeah, great. And we'll make sure to let everybody know when we have part 2. So those of you who are listening today and have kind of unanswered questions or want to hear more about it, you guys can tune in to the next episode that we do about this topic. I want to talk a bit about what does MDMA do specifically that helps with PTSD? What does psilocybin do specifically that helps with treatment-resistant depression? And throwing a lot at you. And let's talk a little bit more about protocols set and setting, kind of the framework, the therapeutic frame, I guess, for this that's important.
Absolutely. So the way I like to think about it is driving on a 2-lane highway. And that's kind of our daily routine, right? And then our brain, when these medications are administered, turns into a 12-lane highway. And we have so much more room to move. And so, you know, I'll speak first to MDMA. You know, not to get too deep. Well, both of them work on our serotonin receptors, which is, for those of you who may or may not know, is our primary feel-good chemical. It's the chemical that when it's balanced in our body, we feel calm, relaxed, ability to feel happy, feel safe, or more easily aroused. We feel more connected when that chemical in our body is well circulated. 90% of our serotonin is stored in our gut system. So when we have a healthy digestive tract, it can circulate better in our system. So both of these, when our brain, our body are under the influence of these medications, our brain is kind of activating more serotonin. So it lights up. Our brain, you know, different areas of our brain are much more activated, neurotransmitters are communicating, different parts of our brain that maybe don't often communicate are connected. And so and I'm going to come back to that in a second, because there's a really important reason why I think that helps with PTSD primarily. But essentially, with MDMA, you think about it like this. So when we go through traumas, our amygdala system, which is the fight or flight response of our amygdala, hippocampus, and the HPA system, they get heightened. And they get super activated as a survival mechanism to help protect us. But simultaneously, the prefrontal cortex, the part of our brain that is responsible for reason, rationale, emotional regulation, gets subdued, because I don't really care how I feel, I need to survive. And when that, in a way, when it gets stuck, or our brain gets in a loop of any time we're reminded of that trauma, we go into that inversion. That's what we call PTSD, and our body responds to it. The beautiful thing that happens with MDMA, and if anybody has done it recreationally, can probably relate to this. The fear response, that survival response, goes down. And guess what goes up? Our emotional ability, our ability to feel, our ability to connect, our ability to see things in different ways. So essentially, say if I'm working with somebody who has chronic PTSD, and every time we get close to talking about that thing that happened to them, or that series of things that happened to them, or that stage of life, they go into survival mode, and their brain says, don't talk about that, don't think about that, we don't want to feel it. The body memories come back, and everything that's protecting us from feeling those feelings. But then we get this medication that says, hey, guess what? We don't have to feel that fear. The part of our brain that says, be afraid of this, the volume gets turned way down. And the part of our brain that says, hey, you can feel it, you can process it, the volume turns way up. And so essentially what happens is we are more capable of reprocessing those memories, because the defense mechanism is kind of incapacitated. We actually let ourselves feel the fear, we let ourselves feel the sadness, we let ourselves feel the anger. Simultaneously, we're feeling more connected. Getting to where you started with earlier is that relationship between therapists. You're feeling more connected in many ways. Maybe you may be reparenting an inner child that comes out. Your ability to process these things that felt stuck for years, maybe even, are coming out and coming to the surface. And then what happens in the integration process after, we're kind of setting those into a way that hopefully has more meaning and more sense to us. And so our brain is reconditioned to say, I don't have to be so afraid of that image or that feeling or that memory. And so as we move past, as we go through the treatment protocols, our brain gets more conditioned to say, I don't have to be as afraid of those images. I don't have to be afraid of talking about this. And so we're reprocessing enough to recondition to not have the trauma response. And our brain response is kind of okay with that, ultimately, to just be simple about it. And there's a lot of chemical actions open, because there was another study that found that older parts of our brain are reopened. So social development, kind of trust, safety, parts of our brain that are closed off in our earlier development under the influence of MDMA are reopened. And so those parts of our brain can actually have a greater influence and say, hey, we're okay. We can actually put this away and don't have to respond with such fear or survival impulse every time we're reminded of something remotely close. So I think, and in all of the training videos, they say there's something metaphysical there along with it.
Yeah.
I think it's wonderful when people experience that, because there's a lot that we experience in this world that we can't fully explain in science. And I think that's an important part to acknowledge because, one of the things that MAPS teaches is that we all have what's called an inner healing intelligence.
Yeah.
You may call that a conscience, you may call that a soul, you may call that intuition, but there's part of us that is pure. The part of us that doesn't know any wrong, that doesn't feel shame, that doesn't feel guilt, that isn't as susceptible to judgment. And I think personally, whether you call that a spiritual, metaphysical, interdimensional, or if that's a brain function, if it's an ego, it's a default network, a default mode network element of our brain is responsible for ego and self-awareness. It says, hey, we can that leads the way in a sense. That part of our brain kind of reassesses how we see ourselves because of what we went through.
Yeah.
Because if we come out of a traumatic experience seeing ourselves as less than or not good or not worthy or a perpetual victim or less, whatever, how, this, how often so many people that have experienced the worst kind of traumas see themselves. If that inner intuition, that inner healing intelligence says, no, we can actually reshape and restructure how we see ourselves beyond that event or those sets of events in our lives, that treatment. Then it gets set in as we go through the integration process, which is the beautiful thing.
Yeah.
Now, I think psilocybin is slightly different from my understanding, in the sense that it actually has almost a dysregulating effect on the brain. It's like turn everything on and everything gets active and disrupts. Say if you have a depression, part of what happens with the brain with depression is that it gets very set, it becomes very rigid.
Yeah, things get
can't
smaller.
see ourselves any different.
Yeah.
It gets smaller.
Yeah.
There's less neural activity in our brain.
Mm-hmm.
Same way with addiction. There's parts of our brain that just don't work. The part of our brain that says you don't have to go take that drink kind of gets atrophied.
Mm-hmm.
And so, to my interpretation and my conceptualization of how psilocybin works on the brain is that it kind of turns everything on. Everything is kind of open, and there's this dysregulating of the stagnant symptom or systems. And then the hope is that if everything turns on and then as it resettles, it settles in the more organic way our brain was supposed to be.
That makes sense.
And so I think that's one part we need to understand more about why and how does that happen. But I think what we're seeing in the data and research is that this kind of dysregulating, this cognitive dysregulation through the serotonin systems being lit up. And then it's like the way I picture it, and I'm a very visual person, it's like taking a snow globe where everything is settled to the bottom and then shaking it up. And then as all the flakes start to resettle, the hope is that it resettles in a way that things are functioning more healthy, that the depressive symptoms and that the way our brain needs to process emotion and feel more motivated, those kind of stay on or get stronger through the process. What the research that I know of, roughly 80% of people that have gone through the protocol psilocybin treatments, 80% are still showing significant remission of depressive symptoms 6 months post-treatment.
Wow.
Which is that's game changing for people. And I think there's a lot of studies that we have to do on how do these things interact, because if you start MDMA treatment, you have to stop all your other psychotropics because you need to know if this is working. Same with psilocybin, you have to stop all your other psychotropics. So that's a risk in my mind of kind of one of your questions. I think we were prepping was like, what are the consequences or the risks of this? Is that if somebody's stable treating their depression on a SSRI, and they want to use MDMA to treat their PTSD, we need a lot to know. Can they stay on that? Do they have to come off of it? If somebody's stable on a bipolar medication, they want to do psilocybin to treat something. Like we need to know much, much, much more about how these chemicals interact with established psychotropics, which we don't have hardly any data right now, at least the field doesn't, to my knowledge. But it's amazing to see, so like you said earlier, that this is fascinating how, like I said, how it circumvents that process in the brain and helps the brain work for itself, because we're working against our natural defenses. Even though our brain tells us this is what we need to do this to protect ourselves, even though it's keeping us stuck in the trauma.
There's so many things jumping in my mind as you're talking.
Yeah.
I know.
That was a little long-winded. My bad.
I love it. No, I love it. I love it. Yeah. I'm just thinking of, and we do have to wrap up, so we're definitely going to have a part 2. But I'm just thinking of when I talk to people, as a trauma therapist, this is just like when you're talking about removing the barriers is really so much of what I'm hearing. You're right, because that process that you're describing with MDMA in particular is what we do, right? It is what we do with people all day long, every day. It just takes months and years sometimes. So removing those barriers and that like seeing yourself differently through different eyes. The way I describe it to my patients is often like you're seeing yourself through your 7-year-old eyes, right? You're conceptualizing yourself and the world based off what happened to you through that developmental stage still. And now you're 35, right? And so that's kind of the way I describe it to people. And like what the goal is we're getting to a place where you can see yourself through your 35-year-old eyes and your understanding of the world and your place in it, and seeing what happened to you as a thing that happened to you at 7, right? So that's sort of like conceptually how we do our work. And what you're saying is that can happen with these medication aids in a much faster period, which is incredible. The other thing that jumped out when I was listening to you talk was this inner healing, right? So a lot of times the way I'll conceptualize that with patients is, just like a plant growing out of the ground or an animal, we are a system that is always striving for homeostasis. We're a system that is always unconsciously striving to heal and striving to find balance and equanimity. And there are a lot of treatments that we say, we're not exactly sure how this works, but we know it works. Even EMDR. Like we kind of know, but there's still like, it could be this, could be that, could be like REM sleep, could be scanning. Like we're not quite 100% sure. And even with medication, sometimes we're not 100% sure. I hear a lot about that. Like we're confident that it works. We're confident that it's safe because we've done all these trials, but we're not entirely sure. So that's not a new thing in our field, behavioral health, that we find these treatments and there's something, and I'm going to say the word, kind of magical about the way it works. Because we don't quite get it as in our human understanding where we are right now. So those a few things were just jumping out to me. I do want to talk next time we have time to meet about access. Is there access? How do people access these treatments, especially since they're Schedule 1 still? I'm sure there are going to be people who are listening to this who are interested in finding out more. And I do want to talk even in more depth and detail about pros and cons, what are things to watch out for, even dosing and, the difference between microdosing and macrodosing. And there's tons to talk about. So let's do this again.
Let's do this again. Very soon.
Thank you so much for coming on. It's always wonderful to see you. I'm sure now everybody who's been listening knows why I still call you for questions and thoughts and to run things by you. You're my forever mentor, and I couldn't be more grateful.
I couldn't be more grateful for you. Thank you for having me on and to your team. This is wonderful, and I can't wait for part 2.
Thanks again, Tony, for coming on. It was such an exciting conversation, and I'm really looking forward to part 2. Thanks, everyone, for listening. If you have any questions, which I'm sure there are questions floating out there about this topic, feel free to email us at pod@apnlodge.com. That's POD@apnlodge.com. You can also check us out at apnlodge.com on the website for more information. For more information, you can also go to our website, apn.com/podcasts. And don't forget to tune in to the next episode. Feel free to like, subscribe, share, and thanks for coming on the journey.